Court is standing session.
Deputy Jones, thank you. On the Conrad Murray case, Dr. Murray is present with his counsel as before. The people by their counsel as before. Dr. White again is present as before, and all jurors and alternates are present as well. Good afternoon, everybody. Ladies and gentlemen of the jury, good afternoon. Dr. White, good afternoon, sir. Do you acknowledge, sir, you're still under oath and still sworn to tell the truth?
Yes, sir.
Thank you. This would be a resumption of cross-examination by Mr. Walgren.
Thank you.
Thank you.
May I have just one moment, Your Honor?
You may.
I have a quotation, Your Honor, from the textbook Intravenous Anesthesia by Paul White. May this be marked People's 236 for identification?
Marked.
Dr. White, can you see that from where you're seated?
Yes, I can.
And do you recognize that as an accurate quotation from your article, Propofol, in the textbook of Intravenous Anesthesia?
I believe it is, although, again, it's out of context, so
Okay.
if you want to show me, that's be appreciated.
May I approach the witness, Your Honor?
Yes, please.
Dr. White, showing you page 120 of your article, beginning with the word because. Could you read that out loud, please?
Yeah, I just wanted to see the whole context.
Take a moment.
Thank you.
Sure.
Can I read it from the start of the paragraph?
No, I want to, first I want you to just reference this and tell me if it's accurate. Is that an accurate quotation?
Yes, it's taken from the middle of a paragraph, a much larger paragraph, describing the use of propofol infusion.
Okay. Do you need to read the whole paragraph to put into context? Is that what you're asking?
Well, I just think it's useful to put things taken out of context in the context in which they were written, so
Why don't you read out loud from the, where do you want to begin reading? From the word propofol
I guess.
to the last word surgeons?
Yeah, propofol sedation has been used to provide satisfactory conditions for upper gastrointestinal endoscopic procedures. Use of an infusion of propofol, 72 mics per kilogram per minute, produced cooperative patient with complete amnesia for the procedure, while providing for awakening and orientation in approximately 4 to 6 minutes after discontinuing the infusion. Patterson and colleagues reported faster recovery and reduced hangover effects following propofol compared with midazolam when these drugs were administered.
A little slower and a tad louder, please.
I'm sorry.
That's all right.
I have a cold, so I'm...
Okay, we'll just sit back if you would. Are you up to the area, or you want Dr. White to repeat anything, Mrs. Theodore?
We can start from hangover, Your Honor.
And reduced hangover effects following propofol compared with midazolam when these drugs were administered for upper GI endoscopic procedures, period. However, the shorter duration of hypnosis following the bolus dose of propofol resulted in more recall at the end of the endoscopic procedure. The use of one or more supplemental doses of propofol would have extended the period of unconsciousness and reduced recall. Similar results were obtained in a comparison of propofol and midazolam for outpatient bronchoscopy. Because of the potential for profound cardiovascular and respiratory depression, propofol should always be administered by personnel trained in the administration of general anesthesia and not by gastroenterologists, radiologists, or surgeons.
Thank you, Doctor. So the quotation on the screen, that is an accurate quotation? And you just read the paragraph preceding it?
Yes, it was an accurate quotation from a book that I published in 1996 and does not represent current practices.
Okay, and so do you no longer agree with this statement?
No, many anesthesiologists, radiologists, pulmonologists, and even surgeons administer propofol in intensive care for sleep and for procedural sedation in endoscopic suites. Oral surgeons administer it for oral surgical procedures.
Okay, so this was kind of the accepted view when your book was published, but it's evolved over the years with wider use of propofol. Is that accurate?
Yes, correct. Textbooks, as you know, are a little bit dated when they're published because it takes a couple years to get all the manuscripts. So I would say this reflects kind of the thinking in the early 1990s.
And would you, then your view now would be, you would still agree that it has propofol has a potential for profound cardiovascular and respiratory depression?
Yes, sir.
All right. But in the appropriate setting, it could be administered by non-anesthesiologists, correct?
Correct.
And in fact, the American Society of Anesthesiologists has specifically addressed this issue and presented guidelines for non-anesthesiologists when using these types of agents, correct?
Yes, I think there are clear guidelines for providing conscious sedation, if you will.
I have two separate quotations, Your Honor. First one may be marked People's 237 for identification,
Marked.
and that's from the Practice Guidelines for Sedation and Analgesia by Non-Anesthesiologists. And an additional quotation from the same document. May that be marked People's 238 for identification?
Yes. Please show them to Mr. Flanagan, who's reviewing them.
Dr. White, do you see People's 237 on the Elmo?
Yes, I do.
Okay. And do you know that to be an accurate statement taken from the guidelines we just referenced? Or would you like to see the guidelines?
I can't be certain without looking at the guidelines, so if you don't mind, I would.
And I do have in my hand a copy of the Practice Guidelines for Sedation and Analgesia by Non-Anesthesiologists, published in 2002. May I approach the witness, Your Honor?
You may.
Looking at People's 237, Dr. White, and looking at page 1011 on the guidelines that I've underlined in red, do you recognize that as an accurate quotation taken from the guidelines?
Yes, it is accurate.
And it states, even if moderate sedation is intended, patients receiving propofol by any route should receive care consistent with that required for deep sedation, correct?
Yeah, any route. Yes, that's what it says. These guidelines are from 2002. I think they've been updated. And my understanding is actually that the guidelines are that you rescue from one deeper level of sedation. That's my understanding of the current guidelines, but I could be mistaken.
And looking at People's 238 for identification, Can you see that, Dr. White?
Yes, I'm familiar with that quote.
Do you need to see the guidelines, or
No, I know that quote.
could you read that out loud, please?
Because it is not always possible to predict how a specific patient will respond to sedative and analgesic medications, practitioners intending to produce a given level of sedation should be able to rescue patients whose level of sedation becomes deeper than initially intended.
Would you agree that when administering propofol in a home setting without the personnel, without the equipment available in a medical type setting, that the best course of action would be to be prepared for moderate or deep sedation?
Yes, sir.
And if the concern is for the patient's well-being and the patient's life, if propofol is being administered in such a bedroom setting without all the available equipment, what should be done is preparation for deep sedation.
Well, I think you said moderate or deep sedation, and I agree with that. If your intended goal is minimal sedation, that is anxiolysis, and minimal, if any, sedation, then it would be moderate sedation, not deep sedation.
And if an infusion line, a drip is running, when you characterize that as moderate sedation at least?
Typically, when an infusion is used, it is, in fact, moderate sedation or conscious sedation, correct?
And so if an infusion is used, it would be typically moderate sedation, in which case they should receive the care consistent with that required for deep sedation, correct?
Yes, they should be capable of rescuing a patient who drifts into deep sedation. I think that's what the guidelines suggest.
You know, I have a picture of the, excuse me, Your Honor, I have a one-page document taken from the practice guidelines documenting the recommendations as to standard of care for moderate and deep sedation. May this be marked Peoples 239 for identification?
Yes, please show it to Mr. Flanagan. Who's reviewing it?
Dr. White, you're familiar with these guidelines that I just referenced, correct?
Yes, I'm familiar in general terms. I couldn't recite specific points. It's quite a lengthy publication.
And it notes that these recommendations apply to both moderate and deep sedation, correct, for non-anesthesiologists?
Yes, sir.
And just going through kind of in summary fashion, they first discussed the need to have pre-procedure evaluation where you get relevant history, physical examination, laboratory testing, and things of that nature.
Yes.
It goes through patient counseling and pre-procedure fasting on number 2 and 3. Is that right?
That's correct.
The section on monitoring recommends pulse oximetry, exhaled carbon dioxide monitoring, blood pressure, heart rate at 5-minute intervals, and electrocardiograph for patients with significant cardiovascular disease, correct?
Yes.
And then notes for deep sedation, exhaled CO2 monitoring considered for all patients, and electrocardiograph for all patients, correct?
Yes.
If you were administering propofol in a home setting, is that the standard of care you would utilize as far as monitoring?
Well, as I said earlier, I wouldn't administer propofol in a home environment, but if I was using an infusion of propofol, absolutely.